Let us see eosinophilic lung diseases. Write down the definition of eosinophilic lung diseases. These patients will have peripheral eosinophilia, excess eosinophils in the blood. Along with that, there will be lung infiltrates. This eosinophilic lung diseases, it can be classified into two groups. Those with a known cause, in whom the cause is not known. Known cause, unknown cause. Under unknown cause, we have acute eosinophilic pneumonia, written as AEP. Then there is chronic eosinophilic pneumonia. It is CEP. These two are very important. I will discuss with help of a table in the next slide. Less important, we have hypereosinophilic syndrome. These patients will have persistent eosinophilia, excess eosinophils in the blood, more than 1500 per mm cube for more than 6 months with end organ infiltration. It means that there will be excess eosinophils in the blood, and these eosinophils will go and infiltrate majority of the organs. If you take a skin biopsy, it will be filled with eosinophils. Lung biopsy, it might be filled with eosinophils. Then we have a small vessel vasculitis that you will come across in your rheumatology, Churg-Strauss syndrome. Small vessel vasculitis, that is Churg-Strauss syndrome. Coming to known cause, most important will be parasitic infestations, especially these nematodes. During their life cycle, they enter the lung. Whenever your lung sees these parasites, it will give an hypersensitivity response. This hypersensitivity response is called as Loeffler's pneumonia. And next important cause is a complex allergic reaction to aspergillus called as allergic bronchopulmonary aspergillosis. Then drugs such as nitrofurantoin, sulfonamides, nitrofurantoin, sulfonamides, isoniazid, penicillamine. These are the drugs that can be responsible for eosinophilic lung diseases. We have classified eosinophilic lung diseases into unknown cause, known cause. In the known cause, parasitic infestations, allergic bronchopulmonary aspergillosis, drugs such as nitrofurantoin, sulfonamides, isoniazid, penicillamine. Let us see the important differentiating features of acute eosinophilic pneumonia and chronic eosinophilic pneumonia. Make a table, on one side acute, on other side chronic. Coming to the smoking history, acute eosinophilic pneumonia, generally you find it in smokers. Chronic eosinophilic pneumonia, the patient may or may not be a smoker. Asthma history not usually evident here. In chronic eosinophilic pneumonia, there will be strong asthma history. Coming to the clinical features, patient will have acute shortness of breath within 1 month. Along with that, hypoxemia, and if you take a chest X-ray, there will be bilateral diffuse pulmonary infiltrates. Bilateral diffuse pulmonary infiltrates. Where did we come across such a presentation previously? ARDS. So the clinical features of acute eosinophilic pneumonia can be similar to ARDS. Now let us see how acute eosinophilic pneumonia is different. Coming to peripheral eosinophilia, initially in the first week not seen, excess eosinophils not seen during the first week of illness, but seen later during course of disease, during course of disease. Now if they ask you regarding bronchoalveolar lavage findings, within the bronchoalveolar lavage it will have more than 25% of eosinophils. Generally within the bronchoalveolar lavage, the eosinophils percentage is only 1 to 2%. Here it will be more than 25%, and these patients fortunately will have good response to steroids. They will be having very good response to steroids. Coming to chronic eosinophilic pneumonia, these patients will have chronic shortness of breath, cough, and on the chest X-ray one can notice bilateral peripheral infiltrates. Because it is a chronic disease, by the time patient reaches you, there will be excess eosinophils in the blood. And bronchoalveolar lavage, this is a chronic disease, so more eosinophils can accumulate, more than 40% eosinophils. And here also the treatment will be steroid. Previously asked question, they will give you a clinical scenario like this. This patient presented with acute shortness of breath. He required mechanical ventilation. You have done a bronchoscopy. Bronchoscopy was showing 25% of eosinophils. Now what will be the most effective treatment? So what is the diagnosis? Your diagnosis should be acute eosinophilic pneumonia. And what will be the drug of choice in acute eosinophilic pneumonia? Your answer should be steroids. From now onwards, whenever I mention steroid, it is mostly systemic steroid, tablet or injections. Whereas these inhaled steroids we generally give in asthma COPD. Let us see radiological features. There are few questions. There is image 1 and image 2. Which is acute eosinophilic pneumonia? Image 1, if you notice, bilateral diffuse pulmonary infiltrates. This is acute eosinophilic pneumonia. Whereas in the second image, if you notice students, in the chest X-ray you can see some bilateral peripheral wing shaped opacities. So there are bilateral peripheral wing shaped opacities. This is chronic eosinophilic pneumonia. Bilateral peripheral wing shaped opacities. You can see opacity just like a wing. You can see an opacity just like a wing. But these radiologists, they don't want to keep it simple. They don't want to just call it as peripheral wing shaped opacities. They decided to complicate. So what one radiologist did was, so he found out that normally wing shaped opacities are also seen in which condition? Cardiogenic pulmonary edema. In cardiogenic pulmonary edema, you see central bat wing shaped opacities. So in cardiogenic pulmonary edema, what do you see? Central bat wing sign. This is called as central bat wing sign. Now this radiologist, what he felt was, in chronic eosinophilic pneumonia, there are wing shaped opacities. If you consider central as something regular pattern, usual pattern, this peripheral is something opposite, reverse pattern. So he called it as reverse bat wing sign. He called it as reverse bat wing sign. So the same peripheral infiltrates, they have given a special name, reverse bat wing sign. Now this radiologist, he was not yet satisfied. He also looked for any other new name in the CT scan. So he has seen the CT scan. In the CT scan also, this is cardiogenic pulmonary edema. You can notice central portion white, peripheral black, whereas here this is chronic eosinophilic pneumonia. You can notice wing shaped opacities. Chronic eosinophilic pneumonia, you can see this wing shaped opacities. You can see this wing shaped opacities. So this is cardiogenic pulmonary edema. This is chronic eosinophilic pneumonia. Now this radiologist, he don't want to call it just reverse bat wing sign. He want to give it a special name. So what he has done was, he has applied a negative filter to this cardiogenic pulmonary edema. See what is meant by applying a negative filter? So this is the negative image, this is the negative filter. So this is the negative filter. So this is a normal image. So in normal image, whatever looks black, in a negative image it looks white. You will be seeing in Instagram also, people will be putting some negative filters for their photographs. Whatever appears white in a negative image, it will appear black. So what this radiologist did was, he applied negative filter to cardiogenic pulmonary edema. So everybody accept this is cardiogenic pulmonary edema, central wing shaped opacities. Now if you apply negative filter, it was appearing like chronic eosinophilic pneumonia. So when a negative filter is put, now the central portion has become black, peripheral is white. It is similar to chronic eosinophilic pneumonia. So from that day onwards, they started calling this chronic eosinophilic pneumonia as a negative filter of cardiogenic pulmonary edema. At that time there were no negative filter, there was no Instagram, there were no negative filters, there were only photographic negatives. So they have named it as photographic negative of pulmonary edema. So chronic eosinophilic pneumonia is also called as reverse bat wing sign. The signs on chest X-ray, reverse bat wing sign. It is also called as photographic negative of pulmonary edema. So the simple name is peripheral wing shaped opacities, but it has been complicated by radiologists as reverse bat wing sign, and it is the same thing, also called as photographic negative pulmonary edema, because the chronic eosinophilic pneumonia CT was looking like negative filter of cardiogenic pulmonary edema. You can see this. When you apply a negative filter to cardiogenic pulmonary edema, it was giving rise to this image. It was looking like chronic eosinophilic pneumonia. So the names are either reverse bat wing sign, or it can also be called as photographic negative of pulmonary edema. Then coming to Aspergillus and lung. How will this fungus called as Aspergillus cause various manifestations? Let us see. Aspergillus in lung, there are three important diseases. First we will discuss ABPA, also called as allergic bronchopulmonary aspergillosis. Then we will go for invasive pulmonary aspergillosis, and in the last we will discuss aspergilloma, also called as fungal ball. Coming to ABPA, ABPA is a hypersensitivity reaction. ABPA is a hypersensitivity reaction by the body to Aspergillus fungus. And what is the type of hypersensitivity? It is a complex of type 1, type 3 and type 4 hypersensitivity. So it is combination of type 1, type 2 and type 1, type 3 and type 4. No type 2 students. It is a combination of type 1, type 3 and type 4 hypersensitivity. Now let us see the diagnostic features of ABPA. The first important diagnostic feature is patient will be having some predisposing history. So it will not be happening spontaneously. Patient will be having some predisposing history of asthma. Majority of ABPA will be having asthma, and recent studies have shown that patients with cystic fibrosis can also develop ABPA, but in majority it will be asthma. And second important thing, there will be peripheral eosinophilia, excess eosinophils within the blood. His serum IgE level will be elevated more than 1000 international units. Serum IgE level will be elevated more than 1000 international levels. And within the blood, there will be elevated Aspergillus specific, IgG and IgE. There will be elevated specific to Aspergillus, IgG and IgE antibodies. So there will be elevated Aspergillus specific, IgG and IgE antibodies. And if you do a skin test, it will be positive for the fungus called as Aspergillus fumigatus. This fumigatus is the species causing all this disease. And if you take a chest X-ray, you can notice upper zone opacities, and on the CT chest you find classical features called as central, also written as proximal bronchiectasis. There will be central, also called as proximal bronchiectasis. Now if you notice here students, predisposing conditions such as asthma, increased eosinophils, increased IgE, increased Aspergillus specific IgG, IgE, skin test positivity, all this indicate there is an hyperimmune response against Aspergillus in this patient. Chest X-ray showing upper zone opacities. Now what is this central or proximal bronchiectasis? In your body, what is considered as large central airway? Your trachea. If bronchiectasis is happening in bronchi, very nearer to the trachea, it is called as central or proximal bronchiectasis. So in ABPA, where is bronchiectasis happening? In bronchi, nearer to the trachea. So this phenomena is called as central or proximal bronchiectasis. Now coming to the drug of choice. Drug of choice for ABPA will be steroid. because this everything is an hypersensitivity, hyperimmune reaction. To bring down that hyperimmune reaction, most important will be steroid. Along with steroid, you can also add antifungal called as itraconazole. So why we are adding antifungal called as itraconazole? To decrease frequency of exacerbations. So to decrease frequency of exacerbations. But if they ask you single drug of choice for ABPA, answer should be steroid. Single drug of choice for ABPA, answer should be steroid. Now coming to invasive pulmonary aspergillosis. This is actually an infection, active pneumonia happening in immunocompromised. Whenever patient's immunity is less, aspergillus can cause a pneumonia. That pneumonia is called as invasive pulmonary aspergillosis. Invasive pulmonary aspergillosis is pneumonia in immunocompromised. Now what is the characteristic features? There will be transbronchial angioinvasion. There will be transbronchial angioinvasion, involvement of bronchus, involvement of blood vessel. Because there is involvement of bronchus, patient can have shortness of breath. Involvement of blood vessel, there can be hemoptysis. Because this is an infection, patient may also present with fever. For your exam, they will ask you what will be the CT chest finding. What will be the CT chest finding during active phase of the disease, and what will be the CT chest finding during recovery phase of the disease. They will ask you what will be the CT chest finding. What will be the CT chest finding during active phase of the disease, and what do you see in recovery phase? Let us try to understand this. Now in active phase, consider this is the lung, this is the lung, okay. Let this be the lung. How will lung appear on a CT film? It will be completely black like this. So lung appears completely black because it is filled with air. Now in this black lung, a fungus is growing. So how will fungus appear? Fungus is made up of solid filament. So fungus will appear white. So the fungus will appear white. Now around that fungus there is also blood, because there is angioinvasion. Blood will also appear white, but when compared to white of fungus, it will be less white. So blood will also appear white, but when compared to white of fungus, it is appearing less white. Now if you see here, there are two densities. Central portion is white because of fungus, whereas peripheral portion is less white. Why it is less white? Because of blood. Now presence of such two densities, it is called as CT halo sign. Presence of such two densities, central white, peripheral less white. Why center is white? Because of fungus. Why periphery is white? Because of blood. Presence of such two densities is called as CT halo sign. Now you have identified and started to treat. Now during recovery phase, what can happen? Now body's immunity gradually can clear the fungus. Body's immunity clears fungus. Body's immunity clears fungus. So whenever body's immunity is clearing the fungus, what do you notice in the recovery phase? Again, let this be the lung. How will lung appear on a CT film? It will appear very black. It will appear very black. In this black lung, a fungus was actively growing. So how will fungus appear? It will appear white. So fungus will appear white like this. Now body's immunity has started to clear the fungus. Once the fungus is getting cleared, what will reappear in that area? Lung will reappear. Once the fungus is cleared, lung will reappear. And what does lung contain? Air. Now you can see air getting reappeared like a half moon shaped structure. What is this sign called as? This is called as the air crescent sign. This is called as air crescent sign. So very important, students. On the CT chest, during active phase of the disease, what do you notice? The sign is called as CT halo sign. In the recovery phase, what do you notice? The sign is called as air crescent sign. So once the fungus is getting cleared, air reappears, and this air looks like a half moon shaped structure. It is called as air crescent sign. Then what will be the treatment? Because it is an active fungal infection, you should give an effective antifungal. It is voriconazole. So treatment for invasive pulmonary aspergillosis is voriconazole. Then coming to aspergilloma. Aspergilloma is neither hypersensitivity nor pneumonia. This aspergilloma is actually colonization in pre-existing lung cavity. Because of some respiratory disease, there is a lung cavity happening. Now in that lung cavity, the aspergillus will come and colonize. Now what do you see radiologically? Consider this is the chest X-ray. Aspergilloma clearly visualized on chest X-ray itself. It can be seen on CT chest also. So those findings easily you can identify on chest X-ray. But for invasive pulmonary aspergillosis and APPA, to see the classical findings, you need CT chest. Now consider this is the chest X-ray. Most important is there should be a pre-existing lung cavity. How will lung cavity appear on a chest X-ray? It will appear black because it is abnormal air-filled area. In this cavity, a fungus is colonizing. How will fungus appear? White, because it is made up of solid filaments. So this fungus is getting colonized. Now if you observe here, again around the fungus there is a half moon shaped structure made by air. This is also called as crescent sign. But to avoid confusion with air crescent sign, it is given a special name called as monad's sign. This is the first finding. Now coming to the second finding, I told you this is just colonization, not invasion. So for example, if the patient is standing erect like this, by gravity in that cavity, fungus will be here. When he turns to this side, the fungus will come to this side of the cavity. when he turns to this side, the fungus will come to this side of the cavity. So there will be ball changing with position with patient's decubitus. So if you take an X-ray, in each position of the patient there will be changing of the position of the ball, the fungal ball. Ball changes its position with patient's decubitus. So next important finding is ball changing its position, ball changing its position, ball changing its position with patient's decubitus, with the patient decubitus. Now what will be the treatment here, students? Already this cavity is destroyed lung. So what I am going to do, this is filled with fungus. So treatment will be resection. Treatment will be resection. Now you can notice here the important findings are monad's sign, ball changing its position with patient's decubitus. It is the same fungus with variable manifestations. Again, this is an examiner's favorite topic. I have made all the manifestations in a single table, because if you see it, you can easily revise it. So if you are dealing with an hypersensitivity reaction, ABPA, asthma, central bronchiectasis, your answer should be allergic bronchopulmonary aspergillosis. If you are seeing it an immunocompromised individual, CT halo sign, air crescent sign, it should be invasive pulmonary aspergillosis. A pre-existing lung cavity, monad sign, ball changing its position, your answer should be aspergilloma, also called as fungal ball. Let us see some questions for you to understand better. This was the CT scan of a patient who is having poorly controlled asthma. His asthma is not getting controlled properly. He is having elevated IgE and central bronchiectasis. Now what is this central bronchiectasis? See here, this is the trachea, large central airway. Can you notice nearer to trachea there are dilated airways, So this is central bronchiectasis. When you find this in combination, what should be your answer? Your answer should be allergic bronchopulmonary aspergillosis. This is suggestive of ABPA, poorly controlled asthma, elevated IgE, central bronchiectasis, everything is suggestive of ABPA. Another case, this patient is a organ transplant patient. He presented to you with some fever, shortness of breath, hemoptysis. This was the first CT. What do you notice here? You can see area which is white, around that there is less white. Here also this is white, around that less white. Such phenomena is called as CT halo sign. CT halo sign. This is suggestive of active invasive pulmonary aspergillosis. Now where did this term CT halo sign come from? Now if you see in the sky on a full moon day, if you look at the moon, there will be central bright area, peripheral dim area or peripheral dim light. So that presence of that dim light around a central bright area, it is called as a halo sign. Remember students, this image is romantic for so many members, whereas this sign is always problematic to a patient. So because you are seeing the same pattern, central bright, peripheral less bright or dim, central white, peripheral less white. So that is halo. It was seen in CT scan. It was called as CT halo sign. Now after few days you started treatment, this was the CT. Now what do you notice here? Air crescent sign. There is air crescent sign. There is air crescent sign. What is the diagnosis here? This will be recovery phase of invasive pulmonary aspergillosis. This is recovery phase of invasive pulmonary aspergillosis, and it is showing air crescent sign. Next case. This was a patient who recently completed TB treatment and chest X-ray is taken. Now what do you see in this chest X-ray? There is a well defined cavity. In this cavity there is a fungus. Around that fungus you can see air lined as a half moon shaped structure. What is this sign called as? This is called as Monad's sign. This is called as Monad's sign. And what is the diagnosis? Your diagnosis should be aspergilloma. The diagnosis is generally aspergilloma. The diagnosis is generally aspergilloma. Same thing on the CT scan. Same thing on the CT scan. You should identify the cavity. You should identify the cavity. In that there is a fungus. Around that you can see air lined like a half moon shaped structure. Again this is a Monad sign. The diagnosis is nothing but aspergilloma, also called as fungal ball. So this is the same fungus with various manifestations. You should know, if it is a hypersensitivity reaction, it is ABPA. Pneumonia in immunocompromised, it is invasive pulmonary aspergillosis. Colonization, it is aspergilloma or fungal ball.